Good afternoon, ladies and gentlemen. May I call to the dais the speakers for this session. Mr. Meena, Director General of Health, Government of Andhra Pradesh. Mr. Meena, please. Mr. Meena, we need you. May I also call Dr. Femida to join us? Dr. Femida, please come. Come. Why don't you sit there? Take a chair there. Dr. Sohal Simrat, please. And Mr. Venkat Reddy. Please. Mr. Meena?
Yes, sir. I think he went out. I'm calling him. I'm going to get him.
All right. We'll just wait half a minute. Mr. Meena has just arrived. Let me start the session and welcome all of you to this session on medication errors and drugs. When a patient gets ill and goes to a hospital, when people go for treatment to doctors, they want to get well. That is why they go. And yet, today, a large number of these people who go to hospitals die, not because of their disease, not because of their illness, but because of errors in medication and because of effects of medicines. The enormity of this problem is not really understood or appreciated by many of us. In the United States alone, the number of deaths due to medical errors is equal to, let us say, every 3 days, 2 jumbo jets crashing and no one surviving. That is the enormity of the number of people, patients who die because of medication errors. 200,000 in the United States, estimate 400,000 in India who die not because of disease but because of medicines. One person in every 10 who come to our outpatients has an adverse drug reaction. One person out of 30 who are admitted to our hospital beds die because of medicines. The WHO 2 days ago brought out in the newspapers, it was front page of the Times of India, that medication errors is one of the top 10 killers in the world today. And this is all over. Some people are more vulnerable. The elderly are very vulnerable. In a Norwegian hospital, 1/3 of all admissions, of all beds, of all patients were there because of effects of drugs, not because of illness. A particular danger zone is what I call the VIP trap, very important person's trap in India. When they are admitted, they get all sorts of medicines. Different doctors come and give different medicines. Interactions occur. And I have a list of VIPs who have succumbed not due to their disease, but due to the effects of medicines. So this is what we are going to do today. We have tried to solve it. We've tried to reduce it. Very limited success. But IT, information technology, may hold the key to our success in the future. So we have a very distinguished panel today. We have the Director General of Health Services of Andhra Pradesh. We have a Director of Patient Safety from Eli Lilly. We have a colleague from Canada, and we have our own Mr. Venkat Reddy, the IT specialist and engineer. I look forward to hearing them, and without more ado, I would ask our first speaker, Dr. Meena, to please come and talk to us. Dr. Meena. Security.
Dignitaries on the dais, ladies and gentlemen. Good evening to you all. The conference going here has been transferring healthcare with IT, and errors in medicine or administration of medicine. That has been the subject. I have just heard 2-3 speakers in the last talking about telemedicine. The telemedicine or the telehealth centers is a new concept that is started with active support of Government of Andhra Pradesh when Dr. Y. Raj Secretary, former Chief Minister, was in the office. As a part of health reforms, the Government of Andhra Pradesh started 104, 108 as a part of a HMRI. The telemedicine system was started in Andhra Pradesh. Though the functioning is not that on a strong footing, but the efforts are going on how to improve the system. So far, improving the health condition of the rural masses is concerned through telemedicine. That is the concept. And of course, the commission or omissions caused by the doctors, caused by the manufacturer, caused by the stockist, caused by the retailer is a subsequent issue. My request will be to you all that we should take some lessons or we should learn something from Andhra Pradesh, a place called Visakhapatnam district in Andhra Pradesh, where this Jan Aushadhi depot, means the Jan Aushadhi is a concept given by Government of India, but district Samakhya means the ladies walking below poverty line. They are called Jan Samakhya, that is an organization. They started about 7 depots in Visakhapatnam district, of which one is the store, major store, and 6 other depots are there. They are delivering Jan Aushadhi, that is called Jeevan Dhara, under the banner of Jeevan Dhara. Now you talk about IT. I was talking to a doctor called Ranga Rao, who is from Andhra Pradesh, a place called Vallabi in Khammam district of Andhra Pradesh. He is the gentleman who was attending all the meetings, conferences with the Chief Minister and all the people of Medical Health Department to propagate and make, how to make this telemedicine system more useful to the society, particularly to the people who are living in the remote forest and the interior area who are not exposed to the doctors and paramedics. I was told that about 25,000 patients have been treated through telemedicine in Andhra Pradesh during 2010-11, and as many as 5 centers were opened, and 3 were in Mahbub Nagar, 2 were in Rangareddy, and I believe Apollo Hospital has put a CT scan machine, I think, in Mahbub Nagar District Headquarters Hospital. So anybody coming from any parts of the district with a head injury or anything, they take the scan and that they forward to Hyderabad, and from Hyderabad the treatment is prescribed, again transmitted back to the concerned doctor, the hospital, and that's how the people are being treated. My friends, this is a revolutionary concept, but difficulties are there that the regulatory system is not effectively permitting as to how to dispense with the medicine. Because all the villages are not covered with the Jan Aushadhi depots. Government, as on date, we have only about 14 depots in the state covered under Jan Aushadhi, and the government has decided of late to establish about 140 Jan Aushadhi centers throughout the state. And when that comes through, and that becomes very, very successful, then we have to go for the second phase. So my request will be for you all. I don't know the experience of other countries. I have just heard 2-3 speakers from South Africa and other countries. That is something great. That stuff you worked out. But one thing is there that Drugs and Cosmetic Act has to be amended, because the drugs cannot be sent through courier or cannot be sent through some other methods. It has to be dispensed with on a prescription. There is no prescription. There are some OTC drugs. There are certain drugs which are to be dispensed with only on the prescription. That is Schedule H. And whatever is not there in the Schedule H, that is part of OTC, loosely speaking. So this has to be looked into, and I think the will is the most important. And I request you all as doctors that you must work out in the particular direction to make the tele-health centers or the telemedicine concept very, very successful. So first and foremost thing, I'll recommend that there should be some amendment in the Drugs and Cosmetic Act, and more Jeevan Dhara, or what is that, Jan Aushadhi depots have to be opened in the state when we talk about Andhra Pradesh, and India we talk about the country. And those things have to be covered with this Jan Aushadhi depots, and Jan Aushadhi depots right now are not having proper medicine, sufficient medicines relating to the treatment of cancer and HIV. So these are 2 things which are very, very important. I'll give a small example of a village called Vallabi in Khammam district, where Dr. Ranga Rao, who has been part and parcel of HMRI, who was the instrument behind this start of telemedicine. What he has done with his experience, he had an old building, he converted into a hospital, and the center, they have installed lab facility, this MRI, CT, all these facilities. So what happens, they take, the patients are coming, they examine the patient, they take this blood test, they conduct urine test, they conduct all the tests, because most of the villagers may be suffering the TB, maybe hypertension, maybe diabetes, or maybe of other problems. And they take the CT, MRI, and they transmit it to Hyderabad, and the Hyderabad, these people receive through the computer, then the doctors look into, and then again they will actually forward, they will actually write the prescription as to what is to be done. Then they will be transmitted, and the doctor will actually give the medicines accordingly. But the problem that those medicines which are prescribed by the Hyderabad center are not available. So that is the most important thing. How to actually make the system of telemedicine you talk about healthcare technology, how to make it more effective. As a DG Drugs Control Administration, Andhra Pradesh government, since I am here since last 5 years, though I am not a doctor, I am an IPS officer, whatever is needed from our side, whatever is to be done by the Drug Control Administration Andhra Pradesh to make the telemedicine or the healthcare with IT support successful, we stand by you, will give whatever the support is needed. So this is the promise I am making on behalf of my department, the government, that whatever is needed from our side, we will do it. The things have to come from the doctors' fraternity, and they have to, and I agree with the gentlemen who are talking on the dais about 5-10 minutes before, that doctors cannot be replaced by the system, by the IT. Only the IT, the telemedicine should support, strengthen the hands of strengthen the hands of the doctors so that they can reach the needy people at the earliest to safeguard their interests. So I totally agree with them. So let us work out as to how to make this IT, health or technology to be more transparent, more successful in the betterment of the life or the health of the people in our country, particularly in Andhra Pradesh, since the venue is Hyderabad. So far, you talk about the errors and all these things in the medicine, the administration of drug or whatever it may be. First, how to go about and all. There is a national health policy which was started in 2005 and 6. I have come without preparation, I am just talking with my experience. The policy says that there should be GMP, good manufacturing practice by any industry. There should be clinical trials, that the first half of a drug, new drug which comes to the market is a part of clinical trial. That's where actually we are committing many mistakes. The ethical committee, which is the institution where clinical trials are conducted, is supposed to have the committee. The committee is supposed to go into all the aspects, the validation of data, the various studies done, the subjects of the trial, whether it's a human being or is a bird or is an animal, they have to do, and they have to do particularly on various age groups. Now take an example, other day somebody said that one particular drug, nice, is banned. It should not be consumed by the children up to the 12 years. It should be there for 12 years and above. Now what is the guarantee? Where is the cutoff? Where is the Lakshman Rekha? How are you going to decide that it should be banned up to 12 and after 12 it is not? Suppose it is there in my house and my one tablet, I'll cut in 2 pieces or 4 pieces if I don't have that particular other thing. So, these are things. So, clinical trials also, when you go for a new drug, it has to be subjected to various tests on all sorts of actually people belonging to the different ethnic groups, different parts of the country and different age group. It might be effective with the young people. What about the old people? The old people might react to the particular drug, might not react. So, clinical trial is very, very important. Good manufacturing practices are very important because that is the basis to manufacture particular drugs to be efficacious, to be potent, to be helpful to the patients. Because that is the idea, whether it's water handling or air handling, validation of data, water, everything. Oh, sorry, I didn't know about. So, these are a part of national health policy. Good manufacturing, then clinical trial when it comes, new drug comes to the market. Since you are doctors here, you must see what is the reaction of the drug, what is the market dynamics, what is the survey, what is happening to the drug reaction, and all these things have to be looked into. So, these are the few things that I thought. Then DPCO, drug price control orders, that is regulated by Government of India, particularly for all the life-saving drugs, you have to see. And then how to administer. So first you must ensure that that particular drug is manufactured with sufficient conduct of clinical trial, and you must observe the the reaction, drug reaction in the market. That is very, very important once it comes into the. And as a doctors, you must see that what is happening. And then many drugs with same brand name, We personally feel, I was in Delhi on 15th of February 2011 in the meeting of Drug Consultative Committee, that is the highest body to decide about the drugs, which drugs should be banned, which drugs should not be banned. I was in the committee. And then we have taken a decision that the drugs, I myself suggested, with the same brand names, but they have got the different potency, different properties, treating the patient for different ailments, they should be banned. We should have the particular brand name for particular type of drugs. Then only things will improve. Otherwise, what happens, doctor writes something. It is a drug, that is some anti-allergy. The doctor writes in a Chalta handwriting. It's not actually in the capital letters. So the pharmacist will understand something, he will give the drug for something else. So, these are all very, very difficult things. And so my request will be the doctors, don't be in a hurry. When you are writing a prescription, write in the capital letters so that it is understood well by the pharmacist. He will deliver the correct drug to the person who is needing the drug. So a few things just I thought that I must tell you. I request you to make the telemedicine more successful in the country, because today we need more concentration in the rural areas, because our 80% population lives in the rural area. And I think the day their health is taken care of by all of us, I think country will go in a long way. Thank you.
Thank you, Mr. Meena, for stressing that with strict regulatory control, obviously the errors will decrease. I have great pleasure in calling our next speaker, Dr. Gaudree Sridhar. She is the Director of Health Informatics at Lawso Health and a professor in medicine and computer science at Western Ontario, Canada. Welcome.
Thank you very much. So what I'd like to talk to you about today is a new way of delivering medication information to the end user through ICT-enabled animation. This is a collaboration between Lawson Health, I Think Research, which is part of Lawson, in conjunction with Sensei. Sensei, just in case you don't know them, is an education content company that combines best-in-class ICT with an evidence-based approach. They focus on healthcare, education to improve adherence, reduce readmission rates, decrease healthcare costs, improve self-management, and improve quality of life using both E and M-based systems. I Think Research is an innovative translation of health informatics and knowledge laboratory that I created at Lawson about 4 years ago, bringing together medicine and computer science. For those of you who aren't familiar with what non-adherence or compliance are, let me just introduce you to it. When a doctor writes a prescription, the patient has a choice. The choice is either to use the prescription or not. On the top line, you see patients who take their medication as prescribed for the duration of the period it was prescribed. You have other patients who exhibit what we call partial adherence. Those patients take breaks from their therapy. And it may be a break for a day, a week, a month. And then we have patients who are non-persistent who stop their therapy before 12 months. We also have in the bottom, as you'll see, a blank line. And that blank line is patients who just don't accept or start therapy. They decide they don't need the medication. The key thing around adherence or non-adherence is behavior. The consumer is in charge of what they do. And a recent study found that behavior is the single largest factor that impacts on healthcare. Compare that to genetics at 30%. We know we cannot modify our genes, but we do know that we can modify behavior. To sort of illustrate the extent of the problem, let me just tell you globally, this whole concept of non-adherence costs the healthcare system $163 billion. 51 billion are allocated to people who mix drugs and have adverse reactions. 106 billion to people who stop using their medication as prescribed. So this is not a small problem. And why do people stop? For many reasons, including adverse reactions, where they may have an effect from a medication that they're not familiar with. Maybe they don't think the drug is working, so they're questioning the effectiveness. And also follow-up care. It's not in the general practitioner's toolbox, as I say, to always provide the information to the patient. We also know that patients rely on other sources. We've heard it from many speakers, whether it's Google Health or just going through the internet and finding information that's contradictory. It also depends upon their social context, who are the people that they believe in, and what is their health belief model. 22% of all prescriptions that are written by the doctor never get to the pharmacy. 14% of prescriptions that get to the pharmacy for the first time and filled are never used. That's 36% of all prescriptions never meet the patient. What happens is not unique to any particular drug class. You can see from this graph that regardless of the drug class, there is a precipitous decline in medication use over time. Think about it. We spend hundreds of millions of dollars developing drugs that patients don't use. And this is only in the 60-some-odd% of patients who actually go and get a prescription filled and use it. What does it mean in terms of the impact on the pharmaceutical industry? The industry, these are numbers from 2001 in Europe. We can see that regardless of drug class, just using antidepressants as an example, it's €1 billion loss annually to the industry. Once again, not unique by drug class. So what is the solution? The solution is really to try to change that 40% behavior that we saw. And why do we need to do this? Because there is a shortage of information that's designed specifically to address the need of why somebody needs to be on a medication. And we need interventions that are dynamic using animation. So this war on medication errors also, the 51 billion that we saw, rely on us being able to educate the patient, engage the patients dynamically, potentially using web-based or mobile systems, evaluate the outcomes. We've heard a lot about data collection, data mining, and utilizing that data appropriately, and finally, taking an evidence-based approach. The components of relevant education, well, the information needs to be relevant, reliable, and applicable. It has to allow the patient to interact, and it has to be active and patient-oriented. We heard earlier about patient-centered education. I believe that animation breaks through some of these cultural and language barriers. And am I the only one who believes that? No. We already know that there is a relationship between adherence and outcomes, and this has been proven over and over again. We've heard previous speakers spoke about David Sackett, Gordon Guyatt, who I've worked with previously. We've done studies showing that this is in fact true. So how does this translate into better outcomes? Let's use blood pressure as an example. We can see that in patients who have been categorized as high, medium, or low adherence, patients who at least use 80% of their medication as prescribed have a 45% better control over their blood pressure. What does that mean? That means that they don't go to see the doctor as often and they don't end up with unanticipated hospitalization. We also know that we have to embrace technology. We've heard about smartphones and web-based systems. But the influence is going to be tremendous. We've heard about Web 2.0. What this allows us to do is modulate our unhealthy lifestyles by helping teach us about food, exercise, and stress. It helps us modulate related diseases like obesity, hypertension, and diabetes. And we also have to look at modulating our changing social circumstances, not just an aging demographic, but unemployment, early retirement, people who don't have access to care, and people who work from home. So the key points we've heard at today's conference are that we need to innovate to deliver healthcare solutions. They have to be patient-centric. They should be deployed potentially using web-based solutions. The solution is really a mentor, and the solution can connect people through web-based systems, advance collaboration between patients and providers, support decision-making, and we know that education can be a solution. I'm going to show you just a quick video that I'll switch over to. of animation that we're using right now with patients, teaching them about their disease. There is technically sound. I don't know if there is sound. We're trying to get sound. So while we're finding sound, the idea is that you explain to the patient what their disease is about. You then engage them so that they learn about their medication and lifestyle changes, and all of that is evidence-based. And then you finally evaluate those outcomes. So this is only 1 minute, and then I'll be done. There should be sound. There is no sound. So I'm sorry that you can't hear it. The whole purpose is that if a patient doesn't actually understand what cardiovascular disease is or what diabetes is, then how do we expect them to actually follow a prescription of medication and lifestyle changes? So some of the work that we're doing now is using web-based systems with patients, helping them understand the disease, helping them understand where the drugs work, and also then ensuring that we're evaluating whether or not what we're showing them is having an effect on better outcomes, including quality of life and adherence to medication. We can probably stop the video and I'll just finish with my summary slide. Thank you. So, in solution, the summary is that a solution has to be comprehensive, and I stress that it has to be evidence-based. It has to be customized because not every patient is exactly the same, and the educational content can include animation because it's dynamic and it's interesting for the patient, and there have to be support systems in place so that we actually target a behavior and then we work with the patient to change that behavior. We've heard a lot about adverse drug reactions, and I think that these types of tools can also be used for phase 4 monitoring and to make sure that drugs are effective post-marketing. Thank you very much.
Thank you. Thank you, Dr. Gaudry. So in addition to regulation, we now have other ideas. Information, education, compliance will also lead to less errors in medication. I now call Dr. Simrat Sohal. She is a pharmacologist and is with Eli Lilly and Company as medical advisor and patient safety officer.
Thank you. Good afternoon, and I'd like to start my presentation by, please can you put the slides, thanking the organizers. And on lighter note, I always have this problem being short in height. If I stand behind the laptop, I'm not able to see the audience. So please bear with me on this point. This one. So what I would like to present to you today is industry's perspective on mitigating medication errors. And this is something very close to me. This is what I do daily. Being a medical advisor, I take care of certain portfolios, and I also take care of patient safety. And patient safety, let me tell you, is very dear to me. So I'll give you the industry perspective, and these are my disclosures, and after this, I'd like to start by putting the emphasis on medication errors. Medication errors are considered to be a serious threat to patient safety, and there are efforts, there are collaborative works going on between the industry. When I say industry, I say pharmaceutical industry, I talk about the local regulators, and I talk about the healthcare physicians. So there's a lot of collaborative work going on between the partners to reduce the medication errors. And how I have designed my presentation is that I will talk about basically standard definitions. I've been here since morning, and I've been seeing that people have been talking about, adverse events. They have been talking about medication errors. I'll just quickly take you through these definitions because they are very close to me as well. And then I will be talking about the specific interventions. And these are very overarching interventions which the pharmaceutical industry, and I will be giving you the Eli Lilly's perspective. How are we partnering to reduce medication errors? How are we partnering to make our drugs easier to use and safer for our patients? So, as I said, even the regulatory environment is very, very up and about on medication errors, and they have their, local systems called the MedWatch. Even the EMEA has its systems which is called the yellow box, where they also report on adverse events, and they also collect adverse events from individual practitioners, and they do a lot of trending to understand whether there's any new benefit or there's any risk to the patient. And what I would like to say is, across all, whether it's a pharmaceutical company promoting drugs or it is the healthcare physician, the end is the patient, and our endeavor is to improve patient outcomes, and patient safety is of primary concern. And WHO has done our job very easy. It has really simplified the definition of adverse event. Even a lay person who is not educated can report what an adverse event is. It's anything that is undesirable, unlikely even, that occurs in a patient after a patient takes a drug. It can be as mild as, I'm not feeling okay. It can be as severe as death or a myocardial infarction. All are reportable. And these are, I won't go through these, but best thing is that we also train our people who are in direct touch with doctors as our sales rep, that if you do not understand, better is to over-report than to keep it to yourself. And now, as we are evolving along the path of adverse events, there are also some terminologies come out like abuse, misuse, medication errors, suspected drug interactions, lack of drug effect, reporting on drug exposure during pregnancy and lactation, and also suspected transmission of an infectious agent. Now, I will be talking about abuse, misuse, and medication errors because these terms are very much interlinked. Abuse basically stands for is like I take a drug for having my own pleasure or for my euphoric high. So it is an intentional overdose or intentional intent to have a euphoric high. It is outside the prescribed label. Misuse is, I do not want an euphoric high, I do not want to be addict, but I want to use it outside the label, which is not prescribed to be by my doctor. For example, a drug that is used in type 2 diabetes also reduces weight, also causes weight loss. So the patient who may not be diabetic will have to use this drug for weight loss, which is a misuse. And similarly, now we talk about medication errors, which is just evolving terminology. And there are 5 rights of the medication errors. And the most important thing is that right patient, right drug, right dose, right route, and right time. All these together are very important, and these are all accidents. All these accidents can happen in this journey of the patient. So we have to reduce these accidents. Most common examples could be a patient has missed a dose, which also constitutes a medication error. A patient has taken expired product, also constitutes a medication error. A wrong drug was dispensed to the patient by the pharmacy or by the nurse also constitutes a medication error. There are many more examples. I will not spend time on this, but we all understand the overarching definition of medication errors. And again, there are some things that are not medication errors. For example, a patient just inquires, what happens if I miss a dose? It is not a medication error, it is an inquiry. So we should understand what is the inquiry, or what is just understanding of the patient vis-a-vis what is a medication error. Last but not the least, again, being from the pharmaceutical industry, it is very important on the timing of reporting. It is very important that you report these events within the time frame allocated by the regulators. And what the industry is doing is, we have the whole gamut of reporting systems. They are known as expedited reporting. They are the PSURs that are generated over a period of 6 months to 2 years as per the cycle of the product, and they are all sent to the local regulators for their review. And what we do at Lilly is that we have a dedicated pharmacovigilance system. We have more than 350 employees who are dedicated to just understand the drug safety, reporting, trending, and sharing the benefits and the risks with our healthcare providers and the patients. Similarly, we also have a column in our website which talks about the patient's role. How can we as a company help the patient in his journey in the disease state? Whether it's the disease or it's a drug. We help partnering with the patient as well. So I've already spoken about this. And this is a very interesting slide. These are the interventions taken by the industry together to minimize the medication errors. So this would explain it in a better fashion. For example, an analog, which is which is a regular analog, which is mixed 25 and mixed 50. So we have different color coding. So the patient is prescribed a regular as well as a mixed 25. So they have different colors. So patient can identify the pen with the help of colors. That can minimize the medication errors or minimize the risk of using the alternate drug. There's another different tactics, different color labels to help patients minimize errors. And not only with the drugs, we also have these programs, patient education booklets. So we partner with the patients as well in their journey, in their disease state, We teach them, or we also partner with the healthcare physicians and train the patients on the disease and how to take the drug, what is the right steps for them. And not only that, we do not stop at that. We also partner with the hospitals in training the technical staff, the nurses, on the do's and don'ts of dispensing the drug. So again, this is my summary slide. We are all imperfect consumers and we are very conservative. So we need to partner together to reduce these accidents. These medication errors are not risks or benefits. These are the errors which occur at our end. So which are human errors and which can be minimized as we walk through and we partner together. Thank you.
Thank you very much for telling us the pharmaceutical side. Our last speaker, Mr. Venkateshwar Reddy, Head of Technology and Solutions, HealthNet Global, Hyderabad. This is Apollo. Welcome. You've heard a pharmacist, a clinical pharmacologist, and now you will hear the real IT.
Thank you. Thank you, everybody. Thank you, sir, and good evening, everybody. Can you help? Well, I think we are running late, so I'm going to take no more than 5 minutes. I'm going to bring the perspective of a technologist on this war against medication errors. Speakers before me talked about various perspectives of the medication errors. I'm going to talk about the overarching theme for both the sessions, how the technology could help bring value, raise the bar of safety, and also help the healthcare reach the masses. But the focus of the theme is essentially war against medication errors. Some of you must have, who were present in the earlier session in the morning of patient safety would have gone through this, would have gone through a lot of sessions about medication safety. Medication errors is one of the biggest challenges the world faces today. I think all of you know the magnanimity of the problem, where it occurs, and the causes for that. What I'm going to focus on is how technology could help contain these and take it to the next level. I'm a technologist. I would like to share my perspective how one can create an error-free medication ecosystem. A minute I'll talk about, most of you know about this, 9 out of 10 prescription errors are preventable. We all know, I think healthcare fraternity knows for generations that there are errors, they need to be tackled, and it needs a systemic approach. Of course, there are 5 rights framework, some of the speakers talked about, and there is a 7 rights framework. But there aren't systems that are available that help you achieve those 7 rights framework today, particularly IT. Second, what you need is a type of knowledge base, which captures various characteristics of drugs, particularly for the drug-drug interactions, drug food, drug lab, various characteristics that create, that actually help these errors occur. Such knowledge base does not exist today in a way that it can be integrated into existing systems. And then a platform-centric approach, which is lacking today, that can help us integrate such systems into the existing deployed systems, where the content which is ever evolving. There are around roughly 40 to 60,000 brands in India, drugs, and around 3,000 to 4,000 generics inclusive of the combinations, and it's increasingly becoming humanly impossible to remember them. And of course, This morning, Barkadat was talking about some type of system where do we record the errors that occur in the care settings? Do we have such system where we can go through, analyze them, do a root cause analysis and feed back the learnings from them, a blame-free error reporting system? So the solution is, this is what as a technologist I see. This is what we believe in, that when you devise, design and deploy a system which captures the knowledge of all the molecules that seamlessly integrates with any healthcare information systems, either in the provider setting or outside the provider setting, that transforms the logic-based information systems into knowledge-driven intelligent systems, helping the doctors at the point of care and service, tell them there could be reactions between these two drugs. There could be reactions between this drug and the patient's history, which will phenomenally help us wage the war against the errors and help us prevent the medication errors. That's what we believe will definitely help us raise the patient safety bar. There is such system that we are building from our company. I'll just walk you through one example quickly. We are doing a beta testing in Apollo Hyderabad with the TCS MedMantra system. Imagine a doctor is prescribing a medicine. He has prescribed rifampicin, and then the patient needs one more medicine, let's say voriconazole, and there is an interaction, negative interaction. Immediately the doctor clicks on add drug. It tells that there is a severe interaction between these two. Would you like to prescribe or would you like to override? There are cases, most of the times the doctor do override given the patient condition. But imagine such knowledge available to you without any effort at the point of care, driven by a knowledge system, transforming simple logic, passive prescription to an intelligent prescription driven by knowledge systems. We believe such systems are the need of the hour. There are various interactions, drug disease. I'll just walk you through. Such systems is what we believe is needed. These are the value propositions of such product. For those who are interested in knowing more, can visit our stall 17. But what we believe is, I think knowledge-based systems which get seamlessly integrated into the current healthcare information systems is where the need of the hour is, which can transform these logic into a knowledge-driven transactions, essentially bringing the intelligence, mimicking the human intelligence. It's the art of artificial intelligence systems. Some parts of the world it's happening, developed world, clinical decision support systems, but focused towards the drug is something that we believe is need of the hour in India. Thank you, gentlemen.
Well, we've had a very good session. I'm afraid due to time constraints there is no time for questions and answers, but immediately afterwards and later in the evening we'll all be available. So thank you very much to the speakers, and very warm thanks also to all the participants. Thank you. This session is closed.
Sorry, ladies and gentlemen, for rushing it up as we are already running very late. I now request our chairperson to hand over the mementos to the panel of speakers. May we please have the mementos. And I also request Dr. Ananta Padmanabhan, sir, could you please come on stage to give away the memento to our chairperson. Ladies and gentlemen, let us all give a huge round of applause for the wonderful informative session.
The memento is being presented to our chairperson. Thank you to all the dignitaries on the stage.